Okay, hello everyone. I'm Dr. Dimitrios Kostopoulos. I am the co-founder and chairman of the board of Hands-On Seminars and the Hands-On Organization. And I am delighted to have with us once again my very good friend and um, co-founder of the Stecco fascial manipulation approach, Dr. Antonio Stecco, who is a world-class authority uh, in general soft tissue, but especially the fascial system. A graduate of medicine and surgery and specializing in physical medicine and rehabilitation. Dr. Stecco, who is coming all the way from Italy for us today, has um, developed together with his father, Dr. Luigi Stecco, physical therapist, and his sister, Dr. Carla Stecco, who also authored the Fascial Manipulation for Musculoskeletal Pain book. He has attracted international attention specifically for their concept in fascial manipulation and the extensive research and clinical results they had in this subject. Dr. Stecco has taught many faculty across the world on this approach, and many therapists and other healthcare providers on the application of the fascial manipulation method with very, very amazing clinical results. So he has been with us webinars before, and today I invited him to rejoin us for a more in-depth discussion on the fascial manipulation concept. But I know that we have with us, first of all, Antonio, welcome. And
well, thanks for the kind invitation and introduction. So really always a pleasure to, to talk, have a chat with you, Dimitrios. So it's really, I think it's a good occasion to, share our background, our knowledge, because we are both coming from, medical physician field, but, we always, come out with the, new concept, and it's good to share idea.
Absolutely. And, I'm going to ask you, so we can get a little bit of the history, like what specifically inspired you to be involved in that area that your father started?
Good question. So when I was a teenager, I was a kind of athlete. So I was doing a lot of sport, and all the athletes have a minor issue, nothing major, but minor issue. And my father, in a way or the other, was always able to fix me. And I was one day I was like the top athletes of my high school. So I mean, I was doing pretty well without training, without any specific. But you don't get injured, you keep training, and so you do well. And then I started to do medicine. At the end, I did orthopedic surgery and PMR as a exam to get in. I get in both, but my sister was already an orthopedic surgeon, and so I said, "Okay, let's do PMR." And when I was doing PMR, I was really frustrated to see the quality of the treatment, the result of the treatment of the classical rehabilitation. That is why I say, look, it was working so well, the treatment of my father. And I see I won't say unsuccessful result that we have to figure out why it works. And so I started to do research since then, because I was spending like a lot of afternoon and doing research from an anatomical point of view and then from physiological point of view to get to where we are right now.
Awesome. That's pretty amazing. And how there are, especially in the realm of physical therapy, chiropractic, massage therapy, there are some other approaches of the myofascia, of the fascial system. What makes the Stecco fascial manipulation approach different and unique compared to others?
So there are two major points. First of all, that you have to know the anatomy of fascia system, or is better, the myofascial unit, something that even NIH right now is promoting. Because even NIH, I understood that the motor unit is not the basic element of function, but it's the myofascial unit. So muscle, fascia, muscle spindle, free nerve endings, all this stuff together that generate the motion. So understand properly the neurophysiology of the motion, and we call like the peripheral coordination of the motion. That of course give you like a plus when it's time to assess any kind of patient. So that is like for sure is like a step one to get be confident what you are doing. Because what I love now that I'm treating, I just finished office, that you're relaxed, because whenever patient come in your office, in a way or the other, you will see that symptoms are related to fascia problem, or fascia is the compensation where a lot of symptoms are generated. Even the patient come for rheumatological problem, neurological problem, and so on. So have a clear idea about the anatomy and the physiology of fascia, give you a plus to understand what I can give to this patient. And in a good way or in a bad way, unfortunately, everybody compensates in the fascial system, because it's the easy way to try to figure it out, to change the biomechanics of our body. The biomechanics of our body is critical related to the fascial system. So we know that at least 30%, but it can be 80%, like the gluteus max, muscle fiber merge in the fascia. So without know the fascia anatomy, we are losing roughly 40% of our biomechanics, but it can be even more. So of course we cannot understand and you cannot assess the patient without know this information. So this of course is taught during our course, so people understand the anatomy, the biomechanics of the human fascial system. It is a big plus. And then, as I said, if you understand the anatomy, you know what's in the depth, because in which depth you have to go to treat. Are you thinking about superficial fascia? Are you thinking about the deep fascia? Are you thinking about the visceral fascia? So there's different depth, different tissue, different symptom, different disorder. It is critical. And we are working even with the Chinese right now to explain even needling should be organized in relation to the depth, because the effect result will be different. And we are now working with a grant in China to try to help to figure it out, the effect if the needle go to the superficial fascia, deeper or even lower. And that has to be explained, because not the same, okay? And on top of that is basically the simplification. So we present the biomechanical human fascial system. So we have simplified the human body in the way that we can basically understand what structure work with what. So we know like synergic structure in different body segments. So you can predict where the body will compensate. So which area you have to treat. Because at the end of the day, what the people are, surprised of this method, that of course is a method, is not a technique. It tells you how to assess the patient, and then the treatment is the easy part. And it does help you to give like a, instantaneous result, but a lot of technique is able to give an instantaneous result. Fascial manipulation is one of the few technique method that were able to give a long-lasting result. As I say always, it's not enough to resolve the pain. You have to give a long-lasting result. To do that, you have to restore the biomechanics. If you restore the biomechanics, you can give a long-lasting result. If you just treat the pain, but you don't restore the biomechanics, the patient will come back with a similar symptom or the same symptom in a few weeks or months. That's what makes the difference. It gives the possibility to run run a randomized controlled trial. It gets successful follow-up.
And Antonio, I think it's important that you are mentioning that this is a system and not just a technique. It's a method, not just a technique. So for anybody who they are not exposed to this method, can you speak a little bit in regard to what is the learning curve for someone to learn it? And let's talk also about what resources are available, especially for people here in the United States.
So, as we say, we have different tissue, different symptom and syndrome related to that. So we have the deep fascia that is the most related to mechanics, and the deep fascia is in particular the one that is explained during level 1. It helps you to treat symptoms that are most related to movement. So I move the shoulder, it hurts. I move the back, it hurts. So these that are classical syndrome that you will face every day, it explains how to be managed with level 1. That is a 6-day course or like a 3-day on-site plus online if you do hybrid version. It is like a typical US way to give a level 1. So in this way, with this 3-day on-site plus online, you are able to manage all these patients that are clearly able to exacerbate the symptom in your office. Very simple. With level 2, you're going to assess and take care of the other 2 extremity. So patients that have pain without motion, I have shoulder pain when I'm sleeping, when I'm driving, or pain with complex motion. I have pain when I do a treatment, when I do I play tennis, when I do, when I don't even know which movement, particular movement. So in these 2 extremity, you will you have to assess the more complex collagen fiber that are in spiral disposition, what we call the structure that is called a retinacula. Everybody know the retinacula of the ankle, retinacula of the wrist, but we have retinacula in the knee, we have retinacula in the elbow, in the lumbar fascia. So all these areas are key area for complex motion. So in level 2, you will be able to manage complex motion or symptom without motion. I have a heel pain, even at rest. Then we have level 3. Level 3 is visceral fascia, but not only that, because people sometimes get confused. So if you are, when we talk about level 3, it's not just a visceral problem, but it can be visceral somatic problem. So you have a knee pain, heel pain due to visceral origin. So the patient comes with a relative clear musculoskeletal problem. But in reality, the origin of the problem is from visceral part. So you have to have all the knowledge of the visceral part of level 3 in order to approach this patient. And so we'll explain the anatomy of the visceral fascia and how to treat global dysfunction. Why I say global? Because the patient have a problem in the visceral and musculoskeletal, like deep fascia. So it is like a level 3. And then we even have a level 4, superficial fascia. That may be something new for a lot of you, but the superficial fascia is well described in literature. They call the Scarpa fascia, the fascia of Camper, of Collins, they have multiple names. But it's the fascia within the hypoderma. So this fascia is very important. It's really innervated. It's more innervated than the deep fascia, but is autonomic innervated. So it works more for autonomic problem, like complex range of pain syndrome, like dysregulation of thermoregulation, like a hypersudoration, hyperhidrosis, eczema, so lymphedema, of course, all these kind of problems that are more complex and we call more systemic. And this is like a, the more advanced course that we give for explaining what is the rule of the superficial fascia.
Now, Antonio, first of all, let me just mention to everyone who is watching our program right now that Hands-On Seminars is hosting your fascial manipulation 3 on July 14 to 16, and you can go to handsonseminars.com to get more information about that. But since fascial manipulation 3 requires as prerequisites fascial manipulation 1 and 2, if you have not done fascial manipulation 1 and 2, you may want to consider taking fascial manipulation level 1 and level 2 with Hands-On Seminars this coming up November 4 to 6. We have the fascial manipulation level 1 program, and then in February of 2024 we're going to have the fascial manipulation level 2 program, and then we're going to be hopefully working with Dr. Stecco in bringing the level 3 once again next year, after more of you have been trained on the levels 1 and 2. And hopefully we'll get to level 4 or so, Dr. Stecco. So let me ask you, can you give us what would be some of the most common conditions that the Stecco fascial manipulation method would be useful for?
All right, so the question is, it's easy to say which one it doesn't work with a fascial manipulation.
Okay.
That would be much easier, but I can tell you like some example that maybe drive people crazy, and then at the end of the day is nothing so difficult. Like the typical like shoulder pain, very acute, even at rest. People are struggling, pain, during the night. I mean, can be easily done by what we call double crash syndrome. So multiple entrapment of the nerve along all the arm. This is quite well described in literature. Everybody knows that there is like an entrapment, but nobody knows exactly where. And through our knowledge, you are able to understand the 2 or more entrapment of the nerve. So you are able to resolve all these peripheral nerve entrapment, extremely common under diagnosticate. So with this knowledge, you can really figure out where it is. That normally people are really struggling because there can be endless number, the place where the nerve can be entrapped. But through our assessment, you can figure out where they are. So this is like I think is a important topic, because everybody think about the entrapment is at the spinal root, okay? But it's not just like that. There is an endless area where the nerve can be entrapped. And the symptom is brachialgia sciatic pain, but for peripheral entrapment. So instead to have unnecessary surgery, you can really give an amazing result, and that will last, because again, the majority of the entrapment, the more severe entrapment, is not at the spinal level, but is more on the peripheral level.
Antonio, I know you have treated lots and lots and lots and lots of patients, but just to make it a bit more real to the people who are watching right now, can you just give us a couple of examples of patients and the perhaps even some examples of failed previous treatment and how fascial manipulation helped them? You're muted.
Yeah. So let's see just what I have today. Okay. I mean, just an example, just come up in my mind. So I just treat like an athlete. He just get like a 2 gold medallion and 1 silver medallion last week. I have the message right here. I mean, it's in Italian, otherwise I will share. I just get today. And so I was happy about this because he was he was a little bit tired. He get also a problem with the girlfriend, but he was a really good guy. But because he have like start to be really in pain, nobody was able to figure it out. He was the coach. He said to the coach, "Look, I want to stop. I'm sick to train like I'm doing because I'm in pain. It's not my. I don't want to go ahead." So the coach sent to me the guy, but I didn't know even that it's like a Olympic, canoa run. How you call it?
Canoeing, yeah.
Canoeing, right? So I treated him, and today he came here, the coach, because he was in pain as well. And the coach told me, you know what? He gained a 20 second in a 1,000-meter canoe, okay, in less than a month, something that is not even believable. So he did like, instead to do like a 4 minutes and 10 seconds, he did like a 3 minutes and 50 seconds. So it is something like incredible, just with like a couple treatments. So I said like this is like I don't even know how it was possible to take it down 20 seconds, in less than a month. And now last week he had like a small Olympic game. They did national one. He get like a 2 gold medallion and 1 silver. So I mean, I changed completely the life of the guy because he was ready to stop, and now he back to the field and doing amazing. But I don't want to say that athletes is my typical patient. So we follow a lot athletes, like a half of the team of LLB, like a baseball team in US. We are following them because of course they need a perfect biomechanics. But majority of my patients are acute patients that are struggling to find out the result. They already try like a multiple therapy, they didn't get better, and so they are coming here. And what I want to say, are more acute are the patient, are better it is. Because with FM, to go down from 10 to 4 is easier. Then 4 to 0, it can take a multiple session. But hyperacute are the best one. So I really invite everybody to take care of the acute patient, because with FM, a couple of points you treat and bam, it drop. So I want to say that it is very adaptable. So you can treat the athletes, you can treat acute patient, really chronic patient that have alteration from top to the bottom. And why not even neurological patient? I have like a patient with a clone, spasm. So this neurological patient, they get better. They get much better because there is a lot of compensation in the fascial system.
You mentioned earlier that you find that radicular pain can be caused more with a more peripheral entrapment. Still, when you have a impingement of a nerve root, is there a place of fascial manipulation method there for a nerve root impingement?
All right, good question. So first of all, why you have a disc bulging, disc protrusion? So we are built up to hold on that, and so the bulging can, if occur like a time after time, like it's a slow process, and then can desidratate. It maybe don't even bother you. But if there is too much tension all around the vertebra, of course the disc have to carry not just the weight above, but also the overtension. And this can generate a disc protrusion and a radiculopathy. Okay, so why we can do better? Because we can decrease all the tension around. You need like a micron decrease of the protrusion to give a relief of the symptom. So the new guideline of British Journal is that surgery should be keep as a last resort. Conservative should be like the first option, even the second option. So there's a lot of patients right now that they are not getting surgery, in particular in Europe, as it was used to. So I treat a lot of them that have a clear radiculopathy, no DAB. There is no, even fascia component. But decreasing the tension all around, in 3 weeks, they get way better than before. Majority of these patients have myofascial pain on top of radiculopathy. So if you take off fascial pain, the patient starts to move. It doesn't have the sharping pain because the fascia is much more sharping than radiculopathy. And then you leave the radiculopathy, is a constant pain, no matter which position you are, is always there. But in 3 weeks, you decrease the tension, is getting better. But the shooting pain that you cannot even slightly move the leg, that one is over. Okay. So, it's not the easy patient to start with, but minor experience, you can really manage this kind of patient that even the surgeons are afraid now to touch, because they see it in 6 months, they know that they will not be better. Okay, because if you leave all the fascial system very rigid, it will be recurrent. Protrusion will occur above, below, so it will be a nightmare, as we know daily in all these patients that have multiple laminectomy and then spinal fusion. This is the typical story of 95% of the patients that start to have surgery. So it will become critical to treat the fascial system to narrow down the patient that really need the surgery from who maybe will not.
Understood. A question came by someone in the Q&A section. They are asking, can you please explain the different course levels, and will we be able to treat patients after level 1, or do we need to complete all courses before we can use this system?
Yeah, excellent question. With level 1, you can already do amazing, because I said all the patients that have a clear painful movement, you can make better. And this is I don't want to say the majority, but the more classical patient. The patient comes in and says, move their shoulder hurts. Bending forward hurts my back. Do the stair hurts my knee. All the patients have a clear painful movement, straightforward. With level 1, you can do amazing result. You will see a lot of patients tell you, you know what? I have pain even at rest. My heel hurts even when I'm driving. My shoulder is worse during the night. Okay. In that case, you need the level 2. And the real patient say, look, you know what? I don't know when I start to have knee pain. And when I'm bloating, even worse. And when I'm constipation, I have low back pain. So you will see that you need level 3 because this patient have a vicious somatic problem, and so on. So with level 1, you see that majority of the classical patient, regular patient, can be managed very well. But of course, you can do much more.
Excellent. Let's talk a little bit about the viscerosomatic pain, and especially with your upcoming course level 3 on that. So what is the role of the visceral fascia, and how intervention can help in visceral and viscerosomatic problems?
Yeah, this is important. So human body have tried to isolate the organ from the musculoskeletal system because, of course, the mobility and motility of the organ are different. But at the same time, we need connection. So, for instance, when you pee, when you poo, you have to have a, control, okay? When you breathe as well. So there is still some connection, minor, but there are. So when you start to have a recurrent bladder infection, immediately every infection will make the fascia more rigid because the fascia is connective tissue, try to isolate the infection. So multiple bladder infection will generate a bladder more rigid. So you have you can have nicturia, and you can have a urgency, but that rigidity, it will affect the pelvic floor. It will traction the fascia that can generate a referring pain in the knee. So the patient comes with knee pain, maybe even bilateral, and say, I didn't have any trauma, I didn't have anything, I don't know why. And the knee pain is even when I'm sitting. So there's not clear painful movement, or there is a pain even without movement. So this is a clear alarm that maybe it's not the classical knee pain, maybe due to the tension of the fascia lata, but this can be a referring pain due to, 1 year of a bladder infection or prostatitis, okay? Or you can have patients that have like a tremendous food intolerance. You have like an irritation, like an irritable bowel syndrome, and then you start to come in your office with heel pain, double heel pain, even at rest. Even when I watch TV, I have heel pain. That is a typical compensation. Why is that? Because human body, lucky for us, try to compensate visceral somatic rather than visceral to preserve your visceral organ. Because of course, it's more important to preserve the visceral rather than the musculoskeletal. So if stiffness, compensation, rigidity has to be, spread out, it will be affecting more the musculoskeletal. And this is why you have mostly visceral somatic problem. But it can be vice versa. You will see later on, very chronic patient, they start to have a lump in the throat. They start to have a short of breath. They start to have like a bloating sensation. They start to have constipation because the stiffness of the container will affect the mobility of the content.
And post-treatment, would you instruct patients to do something to maintain what the provider was able to fix?
Okay, good question. So we are even writing a book about that. So we know that specific exercise, mostly related to stretching, will maintain the adaptability of the fascial system, and it will decrease the severity and the frequency of the symptom. So some minor, stretching exercise can be useful. Of course, it's not mandatory, and the compliance of the patient can be very different. So I normally prescribe for next 3 days when there is a kind of a readjustment of the human body, and that can be very critical. If there is a clear overuse, that will be, should be like a, prolonged to all the time at the patient, or in the specific day where the patient have a very important overuse.
Understood. I want to give another reminder to the people who perhaps joined just recently, or those who are watching us through Facebook right now, that the first level of fascial manipulation course by Dr. Stecco is taking place in November 4 to 6, 2023, followed by level 2 in February 16 to 18 of 2024. You can go to handsonseminars.com to get information about that. And then there is the level 3 course, level 3 program, which this year is taking place in July. That's level 3 with Dr. Stecco, taking place in July of this year. And those of you who have already taken level 1 and 2, you can apply for level 3. I know that there are only, I think, maybe 1 spot left at this point. But those of you who have not taken levels 1 and 2, you can take them next year and take next year's level 3. We've been discussing pretty much every time you and I meet, we talk a little bit about the muscle versus the fascia versus the muscle. Okay, so here is my question. I'm gonna have this time a bit more specific question. when you have a muscle injury, right? So there is some distraction of the muscle fiber, distraction of the sarcoplasmic reticulum, release of calcium. You end up having like kind of a contracted area, overlapping of actin and myosin filaments, decreased blood circulation, decreased ATP and energy crisis, and the whole thing becomes tight from a sarcomere point of view, right? Myo point of view, sarcomere point of view. So what is your viewpoint, or what is the evidence says in regards to the role of fascia in this kind of situation, and how fascial work will facilitate the recovery of this muscle?
Yeah, good question. So the idea is that if you have ITP crisis, I mean, it cannot be forever, because otherwise you get necrosis there. Okay. At the other point, if you have a muscle spindle that doesn't work properly, it can perpetuate a contraction. So the contraction is the manifestation of the dysfunction of the muscle spindle. Now we know the muscle spindle, the capsule of the muscle spindle is perimysium, is poor perimysium. So if the fascia, epimysium, perimysium, even endomysium become rigid, muscle spindle can overfire, and so you can overactivate a motor unit. So who come first, trigger point or fascia disorder? I mean, I won't say which one came first, but I have to tell you that even if a trigger point is first, as soon as you don't get the alteration of the deep fascia, the radiation cannot go out the board of the muscle. Does make sense, no?
Yeah.
So when the patient start to have referring pain go out the muscle border, you know that deep fascia is involved. So you know that you have to assess at least the fascia, because the trigger point is not enough to explain the symptom of the patient.
Understood. That's very important, and I would not agree more than that. It's very, very important, and again, it is less relevant whether you had a fascial spindle muscle dysfunction first. What matters is what will help the situation for this to recover. Are there any recent research? Is there any recent research that has taken place in the area of fascial manipulation?
All right. Well, I mean, we are keeping published article. I mean, I can. We are proud to get evidence, because as maybe maybe people know now, fascial manipulation has evidence. Okay, we publish. We got like as a review that have shown that fascial manipulation has evidence. That is, of course, is something like that is not easy to get, and we are really happy to get to that level. I mean, this is like I can eventually share like my screen just to show up. So an independent group have generate this review, and have clearly show up that fascial manipulation has evidence at the level of acupuncture, okay, and more even the extracorporeal shock wave. So I mean, it takes time, because we have more than 50 articles about fascial manipulation with the randomized controlled trials. So this is like is a huge effort to get there. But since I mean, this publication to 2021, we are proven to have a model level evidence, low model, but in manual therapy is giant step. So is a beginning, but is already something we are doing. So we are keep doing like a randomized control trial, but at the same time, we got 2 grants from NIH for analyze the imaging, the best instrumental analysis to make diagnosis of myofascial pain. And these 2 studies are ongoing in Johns Hopkins and George Mason University.
We have a very evolving healthcare system. Our audience right now is from here, the United States. But I believe that the very high expense spent in healthcare is a worldwide phenomenon. A significant amount of the gross domestic product in the United States is being allocated to healthcare. I would say with the predominant amount spent for the pharmaceutical industry, for medications, and invasive procedures done to patients. Just to give you a funny thing, not so funny actually, the past a few years in the United States, one of the very popular sports that gains more and more notoriety is pickleball. And last year alone, $500 million were spent on injuries related to that sport. It's pretty amazing. But I would say, what is, you believe, the role of fascial manipulation and its effectiveness and the results it gets in the overall healthcare spectrum, and how the learning of it and its proper application can potentially have an effect in dollars spent in healthcare?
Well, we published an article about this from our US colleagues. So what is the key point? So first of all, you have a tool to assess the patient. So we will increase the skill of your manual assessment. That is really something that medicine have forgot in the last century, but is an inestimable, important tool that you have. So with this tool, you can assess and make a clear diagnosis of what's going on. So you can understand if there's a fascial disorder. So this can drop the amount of imaging investigation you have to ask, because you can run out a lot of problems since the beginning. And then on top of that, you have a technique that is costless, that help you to prove your hypothesis, your diagnosis. So in your office, you make diagnosis, you do the treatment, you see the result, and you have received investigation, procedure, and time for the patient. Because you don't have to send the patient in and out of the office to do, MRI or crazy stuff. So this is a tremendous, money saving for healthcare system and time saving for the patient. Worldwide, the patient cannot do 10 treatment and see what's going on then. I mean, this is delirious. It cannot work anymore. I mean, my patient, look, 2 treatment, what can do in 2 treatment, even for a cost perspective, people, they don't have the money that they have in the past right now, and they want to have quick result in a short amount of time. So this is why fascial manipulation works amazing for cash practice. So even in US, people that do fascial manipulation, they move from insurance practice to cash practice. Because in a couple of treatment, you give a result that before you were giving 10 sessions. And when the patient see immediately the result, is more than happy to pay cash right away.
Sure.
And in all the country where you have cash practice, fascial manipulation works amazing. In Europe, Poland, Italy, we have cash practice or a healthcare system that have a endless, time waiting list. It works amazing. In the country where you are forced to go through insurance, it works. But of course, in that case, it depends how is the waiting list of the insurance as well. Okay. But in US, where you're still struggling a lot with insurance, I see it. A lot of people are really happy, and they send me like a lot of mail of kind email to say, look, you changed my practice. I'm really able to get out from paperwork right now, and I get much more satisfaction with my patients. So this is life changing because it's really a different way of living.
Thank you. And we do have a question actually that somebody asked. And yes, if you do have questions, please type them into the Q&A panel. So the question is this method effective for, I think it means for contractures? Let's say you have a Dupuytren's contracture, or you have a hip flexor contracture. Would it work in contractures?
Okay, so if there is pain, yes. If there is no pain, no, in particular in Dupuytren, because Dupuytren have a collagen type 2, so a pathological connective tissue. Until there is pain, you can do a lot. When the patient have no more pain, that is the end. If you don't see collagen type 2, if you don't see like fibrosis, then you can even work for the rigidity. Because fascial stiffness, of course, generates rigidity. But, rigidity with pain. When pain is over, okay, even rigidity is really hard to improve, okay? You can do less. But until there's pain, I say there's hope. Because you will see that the pain and fascia go really together, okay? Fascia is the organ for proprioception. And when there is a disruption, it's not proprioception, but it's a pain perception. So it's a simple sentence that it takes like decades for us to understand, but really, we are really sure that fascia is really the organ for proprioception. So we perceive the body in all our area of the body. So any disruption of this system in any part of the body can generate pain, a bombardment from there. So the typical, non-specific pain.
Understood. I see among the people who are participating right now with us, we also have some electrodiagnosticians. So give us just a quick overview how fascial manipulation will help, let's say, median entrapment at the wrist, or a cubital tunnel, or a tarsal tunnel syndrome.
All right, tarsal tunnel syndrome, I kind of see every day because it's made mostly by the superior extensor retinaculum of the ankle that go all around, because they call just a extensor, but in reality it's a wristband go around. The retinacula becomes stiffer, and the tunnel is made by retinacula. So it doesn't exist like the tendon sheet in the middle of nothing. Every tendon sheet is just a bilamination of deep fascia. So you work with the fascia and make it better. It can be translated to carpal tunnel syndrome. Right there is the carpal ligament. But even if you do a EMG, you cannot put the hand over the fire that the entrapment is right there. It can be above, or multiple entrapment above. To make it really sure that entrapment is only right there, you have to do like ultrasonography, dynamic ultrasonography, and make sure that the gliding right here is perfect, and right here the nerve is squeezed, and the two axes are different. So we treat daily. We publish 2 articles about carpal tunnel syndrome, and we improve a lot. As you know, 15% of people that get carpal tunnel syndrome release, they don't get better because the entrapment was not there. So you need to assess properly the patient. I don't want to say the surgery doesn't work. I want to say that you have better screening the patient before to have surgery. And you save unnecessary surgery, you give faster results to the patient. You have an amazing way to assess the patient, a new tool.
What is the frequency that you see someone? What's the frequency of treatment?
Once a week is more than enough, and is the perfect time frame to let the patient try during the weekend, see how it goes, and check it out the day after, the week after, what is left.
Very good. Before we conclude today's webinar, a quick reminder to all that we have here level 3 of fascial manipulation course in New York through hands-on seminars. You can go to handsonseminars.com for information with Dr. Stecco teaching the July 14 to 16 course. You are qualified to take this course only if you have taken a level 1 and level 2. And anyway, there is only one spot available right now. But we have levels 1 and 2 coming up later this year. In November 4 to 6, we have level 1. Then February 16 to 18, 2024, we have level 2. And then by taking these 2 levels, we'll be able to take in 2024 level 3 with Dr. Stecco. So I guess my final question would be, what's in store for the future of fascial manipulation? You are doing articles, you are doing new books, you're doing new research, but what's in store for fascial manipulation in the near future?
Well, there's a lot of project. We are building up a strong relation with the sport team because in sport, they saw the importance of rehab, and they are seeing the importance of prevention. In the fascia analysis allow you prevention. We published an article about sport injury prevention. We can, decrease the intensity and severity of the injury because you restore the biomechanics since the beginning of the season. And on top of that, we have a lot of collaboration with universities. So we are now in the DPT program, University of Southern California. We are starting the collaboration for DPT in Johns Hopkins. So there are more and more universities that they want to integrate this material in the DPT program.
Very good. Antonio, thank you so much for spending the time with us today in this presentation. It was so informative, and we went also in depth on this subject. And we're looking forward to welcome you in a couple of weeks in the US. So thank you, and see you soon.
Thanks so much for the invitation. See you soon in New York. Thanks again.
All right. Take care, everyone.